and thank you, Suna, for having me do this talk. I really appreciate the opportunity. And just because it's the end of the day, and I know we're all probably a little fatigued and maybe a little hungry, we're going to all practice a small evidence-based intervention to combat fatigue. Would everyone who is a urology nurse or a nurse that works primarily in urology, would you stand up, please? If you can. Okay. And then you guys can sit down. And anybody who works in oncology, would you stand up, please? All right. So there's a few of my people. And then anybody else who is other outside of urology or oncology? Okay. So yes, we've all now done some physical activity, and that's an excellent way to combat fatigue, which is a symptom of both having cancer and most of our systemic therapies for cancer. And I actually kind of tweaked the name of my talk. I know on the flyer for this presentation it says chemotherapy options for bladder and kidney cancer. But the reason why I changed it to systemic therapy is that what we traditionally refer to as chemotherapy is only one of the options, and one of the many options that we have for our patients these days. So I have some objectives here. I am going to sort of breeze through a few things that Dr. Patel already went over in great detail so that we can move things along in the interest of time. So a word about chemotherapy. The word chemotherapy just means chemicals to treat disease. But in oncology, what we refer to as chemotherapy is a specific set of drugs which kills cells directly or alters cell division. So there's lots of different types of chemotherapy. And in fact, in bladder cancer in particular, we use several different agents. I have listed a few here that are commonly used in bladder cancer. Platinum drugs, cisplatin and carboplatin. Those are used in combination with gemcitabine, first line for patients with metastatic bladder cancer. And like I show here, each has a slightly different mechanism of action, either inhibiting DNA replication or cell growth. There's also another regimen that's a combination of chemotherapy drugs that's used in bladder cancer, and it includes cisplatin, as well as doxorubicin, vinblastine, and methotrexate. So some people might be familiar with some of these agents individually, particularly methotrexate, which is used outside the cancer world quite a bit. And again, they all have slightly different ways of killing cells or inhibiting their growth. Try to add a little humor here, because there's so many different chemotherapy agents available. When we go into second line and beyond, the options are very many and would require about 4 more hours of me talking, which no one wants to hear that. So we have another class of drugs, the taxanes, that work a little differently. They interfere with microtubules, which are, if you remember back to thinking about cell division, they're a big part of mitosis. And then there's different chemotherapy drugs that are used in the rare types of bladder cancers. But there's definitely a lot more out there, as I mentioned at the beginning, and those of you, the majority of people here who work in urology are familiar with some of those drugs and administer some of those drugs. So first I want to mention targeted therapy. So targeted therapies, the reason why they're targeted is because they're targeting specific proteins, stopping the growth of cancer. The side effects are sometimes less than chemo. You never want to under-prepare your patients. And a lot of these drugs are available in oral forms, which our patients really appreciate because that's more convenient for them. And targeted therapy agents are very commonly used in kidney cancers. And this is an example of why. So often renal cell tumors have a lot of abnormal blood vessel growth, and we can use that to our advantage. So we have this particular class of drugs that Dr. Patel mentioned, these vascular endothelial growth factor inhibitors, and we use them because that VEGF is overexpressed in a lot of these renal cancers. And these drugs basically inhibit the growth of those vessels, cut the blood supply off from the tumors, and cause them to shrink that way. So here's some examples of our VEGF inhibitors. And if you'll notice, all of them end in IB, so it's an easy way if you're trying to get familiar with these drugs to kind of remember them. There's sunitinib, pazopanib, axitinib, and cabozantinib. And then we have other targeted agents that we use a lot of times in renal cancers, everolimus and temsirolimus. The top one, everolimus, is an oral drug, and temsirolimus is an IV medication. And we also have immunotherapy, so that was mentioned a little bit earlier today. Particularly, BCG is sort of an example of this, using a drug to stimulate the immune system in order to fight the cancer. The drugs that we're using in the metastatic setting to treat both bladder and kidney cancer primarily are these infusions that are monoclonal antibodies, which are targeting a couple of different receptors, which can basically keep T cells activated to continue to fight the cancer. Our cancer cells have a way of basically turning off our immune cells and hiding from them. But these immunotherapy agents help our immune system continue to fight the cancers that are there. So I mentioned there's a couple different pathways. The first drugs that I became familiar with as far as giving infusions or immunotherapy was a drug called ipilimumab, and that utilizes the CTLA-4 pathway and inhibition of that in order to keep immune cells activated. And then more recently, in the last few years, we have the drugs pembrolizumab and nivolumab and atezolizumab, and all of those drugs work in the PD-L1 pathway. So I kind of just already mentioned this, different drugs. And so now I'll talk a little bit more about treatment specific to bladder and then kidney cancer and about their side effects. So I know as a nurse, really what I'm concerned with is how can I best help my patient? How can I get them through this difficult disease and the difficult therapies that come with having a difficult disease? So Dr. Patel talked about a lot of this, things that basically help us decide how to treat bladder cancer. And I know he mentioned a lot about whether or not it's muscle invasive or metastatic or non-muscle invasive. Another thing that is important is making sure that we have those cells and the pathology of them so that we know what drugs are going to be useful for them, because the chemotherapy agents that we would try in a urothelial carcinoma don't work as well in an adenocarcinoma. So we do really need to know the pathology of those cells. And another thing we need to consider is how is our patient? Is this a patient with pre-existing cardiac or kidney issues? Is this a patient that's not moving around very much? We use performance status a lot in oncology to assess the degree of activity that our patients are doing. And it goes from 0 to 4 essentially, and 0 means they're fully active. But a patient with a performance status of greater than 3, which means they're spending greater than 50% of the time in the chair, in the bed, and not really able to do a lot of activity, those patients might be poor candidates and not for chemotherapy and not tolerate a treatment like that very well. And then another thing I touched on was these drugs that utilize this PD-L1 pathway, and that's another thing that we can determine from biopsies. So I think we kind of went over this already. So patients who I would see in oncology would primarily be the muscle invasive and the metastatic patients. Patients that need either adjuvant or neoadjuvant or therapy for metastatic disease where the goal is more palliative. And the other thing I wanted to say on this slide was our patients, physicians do a really good job, I think, of presenting the data, presenting the options to our patients, as far as like, these are the treatments that are available. But I know as a nurse, part of my role has been to discuss, overall quality of life and really try and elicit from my patients what are their goals. Because sometimes that is a weakness, We have these very glasses half full kind of perspectives sometimes, with the treatment options available. But I think it's important to talk to patients about, what is more important to you, quantity, quality of life. If you are going to receive a medication that might make you feel this way, is that acceptable to you? Or would you prefer not to receive that kind of medication? So I do think getting the informed consent of our patients when they're gonna undergo a treatment like this is really important. So this was kind of part of before. Most of these patients with bladder cancer are gonna have the urothelial type of cancer or transitional cell or mixed. The other subtypes are a little rarer and again, treated with different drugs. Okay, so for patients with metastatic bladder cancer, there's a couple of different first-line chemotherapy combinations that are available. If patients are eligible to receive a cisplatin-containing regimen, and I'll talk a little bit more about that in a minute. So one of them is a combination, and I kind of briefly mentioned those drugs at the beginning. It's called dose-dense MVAC, and basically that's just an acronym for the drugs that are involved in the regimen. Methotrexate, vinblastine, doxorubicin, which is also called adriamycin, and cisplatin, or a combination of gemcitabine and cisplatin. And then if patients aren't able to receive cisplatin because of pre-existing conditions, they could receive gemcitabine and carboplatin, which is a little gentler in a lot of ways. And then we also have the option to give them immunotherapy. So I'm gonna skip forward a little bit. So a year ago, if patients were cisplatin ineligible, we would tell them, well, you could get chemo with carboplatin and gemcitabine, or we could give you these immunotherapies, which a lot of people tolerate very well. And most people would go the route of immunotherapies. But recent data, actually, I'm not sure where my slide is, but the more recent data that's come out is, on this one, has shown that for patients who do not express a lot of this PD-L1, they don't do as well with immunotherapy. They're not gonna respond as well. So back to what I said before about the importance of making sure that we're sending the biopsies off for these results so that we can see if they're a candidate for immunotherapy, if they're gonna respond well to immunotherapy, or if we need to just give it a go with the chemotherapy. So that's just as of this year that this guideline was changed. So what makes someone eligible for cisplatin? You gotta be pretty healthy. One of the hugest toxicities from cisplatin is that it can be toxic to the kidney. So we're giving this oftentimes for bladder cancer regimens, and the last thing you probably want to do is put them in kidney failure, but that certainly can happen. So we need to get a baseline creatinine clearance for these patients. It needs to be above 50. Additionally, there's some recommendations that the patients receiving this type of therapy have an ejection fraction that's over 45%. If there's any suspicion about that, definitely send them for an echocardiogram. And even more so than for cisplatin, patients need to have no pre-existing heart failure when receiving doxorubicin, which is a drug that can be very cardiotoxic. Cisplatin can cause a fair amount of neuropathy. And for a lot of these patients getting these cisplatin-containing regimens, if they're going for a cure, if they're getting neoadjuvant or adjuvant chemotherapy with just muscle-invasive disease, we need them to be able to walk and to use their phones and to type and to function. So assessing neuropathy ahead of time before giving them a drug that can cause worsening neuropathy is really important. Same thing with hearing loss. So patients with pre-existing tinnitus or hearing loss, should get some hearing tests beforehand, and that would be a caution in giving cisplatin. You wouldn't want to make your patient deaf if you could avoid it. And the other thing is performance status, which I talked a little bit about. So this is not an easy treatment to tolerate. We can't, a lot of people do tolerate it, and we have good drugs to help now, but patients who are really not very mobile and who are really not very healthy otherwise might be poor candidates for regimens containing cisplatin. And I'm going to talk a little bit about chemotoxicities. I could spend an entire hour talking about just this, for sure, and in fact often do spend an entire hour talking about this with my patients, educating them when they're receiving these new regimens, making sure that they understand all the possibilities, and also probably making them a little nervous sometimes. But it is really important for people to understand. A lot of people are aware that most chemotherapy drugs are myelosuppressive. So we need to watch out for neutropenia in these folks, thrombocytopenia, and anemia. The nadir for a lot of these drugs is between, so the point at which the blood counts will be at their lowest is between a week and 2 weeks. The drugs vary a little bit between them, but of course our patients are getting a combination of different drugs. So, again, just watch for it between a week or 2 weeks after treatment. And that's why the dosing schedule for a lot of these treatments have breaks in between, where you're getting treatment once every 3 weeks, once every 2 weeks, or day 1, day 8 of a 3-week cycle. The other thing that we can use to counteract the neutropenia is Neulasta, pegfilgrastim, which is a stimulator of the white blood cells. And that helps keep our patients out of the hospital with neutropenic fevers, which is an oncologic emergency. GI toxicities, that's probably the worst reputation that chemo has. Everybody assumes that chemo is going to make you throw up all over the place, which sometimes happens. But a lot of times we're able to manage this, and now we have some evidence. I kind of spent a lot of time on the Oncology Nursing Society. They're putting evidence into practice guidelines, looking up to make sure that what I'm doing is actually the latest current evidence. One of the things we need to know before we start making a plan to manage the nausea and vomiting for our patients is that these drugs vary in emetogenicity. So cisplatin is a very nauseating drug. Doxorubicin is a very nauseating drug. Gemcitabine is not. Again, when you're using them in combination, you're probably just going to lean towards the drug that has the most emetogenicity and then proceed cautiously from there. When we give chemotherapy, we always, if it's an emetogenic drug, we always give pre-medications with some kind of antiemetic. And the choice is based on how much nausea that type of drug causes. So we have a number of different types of drugs. We have your 5-HT3 antagonists, which is all the ondansetron, palansotron. There's a whole bunch of different ones. They come in oral forms, they come in intravenous forms, they come in dissolving tablets, and they even have patches. So you can find a way to get the antiemetics into your patients. And then another thing we do for the patient, for regimens that cause a lot of nausea, those cisplatin-containing regimens in particular, is make sure that they go home with a schedule to follow. So they should be taking scheduled medications to prevent nausea, because there can be both acute nausea and delayed nausea for up to a week with higher doses, particularly of cisplatin. I was sort of surprised, but not really, to see that Oncology Nursing ONS recommended cannabinoids and cannabis on their nausea and vomiting management guidelines. That's something that patients ask me about constantly now, and a lot of people have had come to me saying, this has been very effective for me, but now I'd like to try it through the proper channels. We're still kind of gathering data as far as the uses for these types of substances, and it really is kind of based on your institution. We do have a palliative care team that will guide people through the process of getting, medical marijuana. And I think that kind of is probably becoming a little more common. And there's some non-pharmacologic interventions to helping with nausea and vomiting, and that includes guided imagery, relaxation, and education. So like I said, if we make sure that patients understand what to expect up front and how important it is to take these antiemetics and when to take them, they're going to have better outcomes. There are plenty of other GI toxicities, including mucositis, which is fairly common and can be dose limiting. And we just need to teach our patients about good oral care. Cryotherapy is still listed on the management guidelines, but not utilized as much before because a lot of the drugs that we're giving have these really long half-lives, and you can't chew ice for like a week straight. It's just not that practical. Constipation is fairly common as far as a GI toxicity for patients. You're going to manage it with your over-the-counter, laxatives and stool softeners and things like that. I did want to say, particularly for those of us who are treating patients with a lot of pain, patients with metastatic disease, and who are on opioids, it's important to kind of look at the source of that constipation, because we would use different agents to treat opioid-induced constipations sometimes. And there's a lot of opioid antagonists out there that work locally to help with these types of constipation. Diarrhea. Certain chemo drugs can cause a lot of that. Most of the drugs we're using in bladder cancer aren't necessarily going to cause a lot of diarrhea. If I am giving a drug that might cause that, I ask people to have some loperamide on hand, and then hydration is of the utmost importance. And then there is some expert opinion support for a BRAT diet. Peripheral neuropathy, I already mentioned. Platinum drugs, vinca alkaloids, taxanes are huge culprits as far as chemotherapy drugs that cause peripheral neuropathy. And like I said, these issues develop during the course of treatment, and then some people have a significant improvement after treatment is done, and some people have neuropathy for the rest of their lives. And so because it can cause long-standing gait problems, pain problems, we want to make sure that we're proactive at managing it, and it can, require a dose reduction of the chemotherapy if people are having substantial effects. The opioids are helpful in managing pain from peripheral neuropathy. I know we try to minimize that as much as possible. Gabapentin, duloxetine are also effective. I mentioned hearing loss, so ototoxicity can occur with both the platinum agents, particularly cisplatin at higher doses, and vinca alkaloids. So the regimen that I mentioned at the beginning, dose-dense MVAC, contains 2 of those drugs. So people who are receiving that regimen for either their metastatic or their adjuvant chemotherapy, we need to be assessing those folks for any hearing loss and referring them to audiology. Nephrotoxicity, you guys know a lot more about that than I do, just in general. But like I mentioned, it's fairly common and can lead to electrolyte imbalances. Patients that are receiving these regimens containing cisplatin, which is highly nephrotoxic, are going to receive a lot of hydration on the day of treatment. Usually people are receiving between 2.5 and 3 liters of fluid total through the course of a 5 to 6 hour period. So that's a lot, but that doesn't cover all the bases. I do a lot of talking to my patients about how much they're drinking at home and how very, very important it is, and encouraging both water and electrolyte drinks. Also want to make sure that people, if they can avoid other drugs that are nephrotoxic, that they do, and then discourage the use of NSAIDs while we're treating people with these types of drugs. Cardiotoxicity, again, anthracyclines, doxorubicin is the main drug that we're using in bladder cancer that can cause this, and it's pretty scary, primarily because patients who have been treated with chemotherapy containing doxorubicin 20 years ago can still turn up with heart failure. So we need to, this is sort of underscores the importance of survivorship with these patients. So this is kind of like a hot button topic right now, that it's great that we're like increasing the long-term survival for these patients, but we need to keep following up with them with someone who understands the side effects of the treatments that they've received, both their urologic procedures as well as the chemotherapy drugs. It can happen acutely as well, and the most important thing is recognizing any changes early and making sure that we have that data have their ejection fraction before we're initiating any treatment for those patients. So again, I kind of went over this. There's a drug called Zinacard that we use in some patients, and that has a cardioprotective effect. And the other thing is that the guidelines say that you should have there's a cap on the dose of doxorubicin someone should have through a lifetime. So if patients are having like a recurrence and have gotten chemotherapy in the past, it's really important for us to like go back and look at those records and see how much of what drugs they've gotten in the past. Because again, this is a lifetime maximum for doxorubicin. That's less than 550 milligrams per meter squared. And the reason is because the risk for heart failure and other cardiac issues, arrhythmias, et cetera, goes up significantly once we get past that dosing threshold. And like I mentioned, I could talk about this for a long, long time. Fatigue is one of the big things that we see with chemotherapy. We'll talk about that a little bit more because our other therapies cause that as well. And alopecia, most people are aware of. Some drugs cause it, some drugs don't. So if you're getting cisplatin and gemcitabine, we don't really have to tell our patients like to go see the American Cancer Society about getting a wig, because they're going to have probably very little hair loss. Conversely, patients getting dose-dense MVAC will probably have some hair loss. There's a lot of dermatological toxicities possible. We see infusion reactions, like people having an allergic reaction during their chemotherapy treatments. Fertility problems, which can be long-term, and definitely in the short-term, sexual dysfunction. And then, for patients who are a little older, who have other comorbidities, we need to do a careful medication reconciliation to make sure that we're checking for drug interactions, because there's quite a few with chemo drugs. So now I'm going to talk a little bit about immunotherapy toxicities. They're a little different than chemotherapy toxicities. And we manage them very differently. So here's kind of a list of them, and if you don't take anything else from this, just remember steroids. Most of our immunotherapy toxicities are managed by giving steroids. So if you remember, our mechanism of action for immunotherapy is it's keeping our immune system turned on. So giving a steroid that can suppress that immune response is going to help suppress those adverse effects. And I'll kind of go through these. I don't know how we're doing on time, but the most common thing that I see with giving immunotherapies, and like I mentioned before, the immunotherapy drugs that we're giving in bladder cancer are primarily pembrolizumab or atezolizumab, and those are in those high PD-L1 expressing patients. But we see a lot of dermatologic toxicities. Rash, or sometimes just itching. People sometimes are terribly itchy without having any visible rash, which can be pretty disruptive and cause problems with sleep. So if it's mild, we're going to continue with therapy. Recommend antihistamine, especially if itching is the primary symptom. Topical steroids can be used if it's more mild, and if it's more severe. And then good skincare, like with the lotion, particularly right after bathing. If it's covering more of the body surface area, up to 30%, we would consider holding treatment, starting folks on either a higher potency topical steroid or starting with oral steroids, antihistamines, lotion again. And if it's more severe, we would hold and or discontinue the therapy, and again with the topical and oral steroids. If it's more severe, also I would probably refer them to dermatology. Colitis is another common immunotherapy toxicity that we want to look out for. So these drugs can lead to inflammation in the bowel. A lot of times it's mild. So if patients are having less than 4 bowel movements a day, they can take Imodium. If they continue to have frequent stool, or if they're having bloody stool, mucousy stool, then we would want to hold their immunotherapy. One of the things that I didn't say at the beginning was with chemotherapy, we can do dose reductions. With immunotherapy, we give it or we don't give it. We don't really adjust the dose. It doesn't make a difference. It's either you give it or you don't. So for moderate colitis, we would hold. And then, people can have diarrhea for a multitude of reasons. So we want to kind of delineate where is that diarrhea coming from. Is it infectious? So do some stool cultures, some blood work, to rule out the possibility of infection. Recently, I saw a patient who had both immune-mediated colitis and C. diff, and so we had to treat both of those things. I feel, it was an awful experience for that poor person. More severe, obviously, you're going to definitely hold, probably discontinue the immunotherapy. Make sure you're doing stool cultures. For more severe cases, patients probably are going to be hospitalized and receive IV steroids, at least for a few days, and then convert to oral steroids. And patients, this should be included in the education. A lot of times we need to keep these patients on steroids for a long time. I'm not talking about a 6-day Medrol pack. I'm talking about 4 to 6 weeks of being on steroids. And so we have to think about what are the potential implications of that. Are your patients diabetic? Are we going to drive up their blood sugar with these longer-term steroids? Things like that. So colitis, a lot of times it's mild, but it can be pretty nasty. This is also where if the steroids aren't nipping in the bud, we would consider the immune modulating agents like infliximab, which can be infused, and it can be given a couple times if needed for more refractory colitis. Hepatitis is something that we see sometimes. So patients coming in for therapy get routine blood tests every time they come for treatment. We're doing a metabolic panel to check their LFTs, check their kidney function, make sure everything is okay. So if we see elevations in the LFTs, we would first monitor them more frequently. If it's more than 3 times the upper limit of normal, we would want to hold the immunotherapy, do more frequent monitoring, make sure that this is not because all of a sudden there's a progression of disease into the liver, or there's possible viral etiology, and start some prednisone if we have decided that this is in fact immune-mediated hepatitis. And then for more severe elevations in LFTs, we would discontinue and send them into hepatology. Endocrinopathies, this is another one of the pretty common ones that we see, especially since immunotherapy is given sometimes for a longer duration. Patients are on this for months and months. And the other thing is that these toxicities can occur even a couple months after patients are off therapy. So that's another educational piece. The most common thing is issues with the thyroid. So we do check a TSH initially on our patients, and then periodically throughout treatment. And if they're normal, then it's only going to be once every couple of months. If we see an abnormality in the TSH, then you're going to reflexively do your T3, T4 and monitor a little more closely. The nice thing about thyroid issues is that hypothyroid is much more common than hyperthyroid. A lot of times people have an initial hyperthyroid that then just sort of fizzles itself out and they become hypothyroid after a couple more weeks. We kind of just monitor until the TSH becomes greater than 10, and at which point we'll start using some Synthroid for these patients, just like you would with anybody else. And then just keep an eye on it, because it can continue to change. We have patients with pre-existing thyroid issues that then a lot of times need dose adjustments once they start immunotherapy. One of the scarier things that I saw recently was a patient that we were treating with a combination of immunotherapy drugs, and he was only in his 20s, and he developed type 1 diabetes, presented with a blood glucose of 450. So, obviously if you develop type 1 diabetes, you need to be on insulin According to the guidelines, you can continue to treat these patients if they present with blood glucose of less than 250 and no diabetic ketoacidosis. But be cautious there and make sure that you get endocrinology involved. And then it can also cause rarely some pituitary inflammation, and we're going to leave that up to the endocrinology experts to manage. Pneumonitis is another possible toxicity. We see this in the mTOR inhibitors as well. So it's inflammation in the lungs. Sometimes this is found incidentally when we're doing our typical scans to assess whether or not people are responding to these therapies. If it is found in any kind of pneumonitis, we want to hold the immunotherapy. I'll say that first. If it's incidental, patients are asymptomatic, you just want to make sure to re-image. With patients who are symptomatic, patients who are like hypoxic, who are having a dry cough, who are having difficulty breathing, we want to make sure that they don't have either worsening disease in the lungs, some kind of underlying infection, and probably get them started on some steroids pretty quickly. And then if it's more severe, we're going to discontinue the drug and make sure that they have IV steroids and probably an admission if needed. Something that's gotten more attention lately, but which when I started giving immunotherapy wasn't kind of a topic that we really spent a lot of time on, was cardiovascular toxicities. But recently, where I work, we have started, or we will be starting very soon, checking troponins when we initiate immunotherapy for patients, because there's been some more data recently saying that that patients receiving immunotherapy have severe issues like myocarditis, pericarditis, arrhythmias, and issues with ventricular function as a result of it, and we need to kind of keep a close eye out for those things. We do also there are cardio-oncology specialists in certain institutions, and I think where I work at Rush, we're really lucky to have one, and she's pretty brilliant, and because she's an expert in oncology and also an expert in cardiology, and with all the issues that these drugs can cause, it's really helpful to have someone like that to refer to. There's numerous musculoskeletal and nervous toxicities that people can have. For a lot of the nervous toxicities, you would discontinue these drugs because they're more severe. I've seen a lot of patients with like rheumatoid arthritis have flare-ups once they start, or pre-existing inflammatory issues. You got to watch these folks closely if you're giving them something that's likely going to cause inflammation or that can have inflammatory side effects. So again, that's something to assess for each time. And then, as with everything, steroids are going to be your intervention. Okay, so a little bit about kidney cancer. Immunotherapy drugs are used in kidney cancer, and so I'm not going to spend too much time talking about those drugs again, but we'll talk specifically about the side effects of those VEGF inhibitors that are used commonly. Dr. Patel, I think, went into this, so I'll kind of skip over that. And I just kind of put in the guidelines for patients who are later stage surgically unresectable, because those are the patients that I'm going to see in oncology and be giving these systemic therapies to. Clinical trial, actually, according to the NCCN guidelines, is always going to be, hopefully one of your first options for your patients if you have that available to them or can refer them to one. And then a lot of the drugs that you can see here are these VEGF inhibitors, your pazopanib, your sunitinib, axitinib, and cabozantinib. We also have a combination of two different immunotherapy drugs, the ipilimumab and nivolumab, and that's for patients who are poorer risk. And then I think Dr. Patel mentioned interferon and interleukin-2. We don't use those drugs as often. People a lot of times have to be hospitalized to receive those treatments. They're very work intensive and have a lot of side effects. So generally these VEGF inhibitors are higher on a patient's preference, and the efficacy is very good. So again, sorry, this is a very heavy in the pharmacological stuff talk, but there's a number of VEGF side effects. The single most common is hypertension, okay? In fact, for sunitinib, that's an indicator of overall survival if patients develop hypertension when they start therapy. So you kind of want your patients to get hypertension, but then you kind of need to manage it very well. So the mechanism of action is just this stimulation of the production of nitric oxide, and that's done by VEGF, and we're inhibiting that process, right, causing vasoconstriction. So patients who have pre-existing hypertension, we need to make sure they're very well managed beforehand. Their blood pressure should be less than 140/90. And then when they initially start therapy with one of these VEGF inhibitors, we should be monitoring their blood pressure at least weekly. So for some of our patients, we can instruct them, on how to use a home monitor and trust them to do that. But if they're not going to do that, then they need to come in and have it checked on a weekly basis. And adjustments need to be made to their antihypertensives. Interestingly, drugs like amlodipine can have CYP interactions with these VEGF inhibitors, and you want to try to avoid them. And then if patients become severely hypertensive and you need to have a treatment break, you want to reassess their hypertension during that time. There's a number of GI toxicities, and I'm not going to spend a whole lot of time on this because the management of these are actually similar to how you would manage GI toxicities for a patient receiving chemotherapy. So your typical antiemetics are helpful for patients having nausea, which is fairly common, 26 to 58% for all grades receiving the drugs that you can see on the left side of the screen there. And then diarrhea can be very common as well, okay? So like I mentioned, these drugs, it's a bottle of pills that we're giving to our patients. They think, great, no big deal, better than chemo. Not always. So it's definitely important to make sure that they know what to expect and when they need to call us. Mucositis can be an issue, and I don't think I talked as much about this before, but having patients avoid alcohol and alcohol-containing mouthwashes can be helpful with mucositis. Stomatitis cocktail, which is a mixture, if people aren't familiar, of Benadryl, lidocaine, and Maalox, can be helpful in managing mucositis. And then if people end up with a bunch of ulcers in their mouth, we need to give them a break from these drugs. And then anorexia is a big issue. If you have a dietitian that you work with, I utilize our dietitian quite a bit for patients with appetite issues. We can recommend smaller, more frequent meals and supplementation, of course. Appetite stimulants, we don't use as much. There's a lot of people that I've been working with recently who have had success with like cannabinoids for appetite stimulation, but we're not prescribing things like Megase very much. I don't know if people are familiar with this drug because there are risks associated with that, specifically an increase in DVTs. So for VEGF inhibitors, there's kind of an unusual dermatological toxicity called palmar-plantar erythrodysesthesia, and this can be mild, can just be some swelling, some irritation, some thickening of the skin on the palms of the hands and the bottoms of the feet. But it can, get to the point where it's peeling, blistering, like open wounds. And so we need to kind of educate our patients and monitor. In order to prevent that, you want to make sure that you tell your patients to avoid contact with hot water, because hot water can lead to its development. Avoid friction. Make sure they're, not wearing shoes like the ones that I'm wearing right now. Comfortable shoes and socks that are, the right size, and keep their skin moisturized. So as with most other treatments, we're going to keep an eye on a lot of the labs. So we'll be checking a metabolic panel, monitoring LFTs through treatment, And the recommendations for how often you do that is going to vary by the drug. Some of these VEGF inhibitors cause more substantial hepatic toxicities, and you would need to monitor them more routinely. A lot of times when we start patients on these drugs, we do check their labs more often, and then if they are tolerating them very well for several months, then we sort of stretch out the time that we're checking. And then of course if abnormalities occur, then you want to increase your frequency of checking your LFTs. And then hypothyroidism, same exact management as you would with immunotherapy, where you're monitoring and prescribing Synthroid if TSH becomes elevated. So I mentioned fatigue at the beginning, and I know this is the end, so everybody's having some of that right now, but fatigue is such an important thing to consider in cancer treatment. It's multifactorial. It's never just from one thing. And so one of our jobs is to make sure that we're talking to our patients and figuring out what are the contributors to the fatigue. There's a few things that are pretty easy to correct. Endocrine, for example, if your patient's fatigued because their TSH is 32, that's fixable. If they're fatigued because they can't sleep, again, that's something that we can help them with. There's a lot of things that we can do to intervene, but it depends on the cause of that. Exercise is going to be the #1 intervention for fatigue. I talk to every single patient about exercise. I'm a little bit of an advocate about that, but it's so good it's helpful for constipation, it's helpful for everything. But it is an evidence-based intervention, and I'm not telling them to go run a 5K or the Chicago Marathon next weekend or anything like that, but just to move, not to stay in the bed all day. And it's hard, because people have had surgery, people are getting these chemotherapy drugs, but it is really important to educate them to do that. And then, obviously sometimes people need to conserve their energy, so we can recommend grouping their activities if they're really having a lot of fatigue, and making sure they have time for rest breaks. And then the ONS guidelines also recommend massage, although that's not usually covered by insurance. Yoga, again, not covered by insurance, and probably not something a lot of our older men are necessarily going to get into, and ginseng. So just wanted to say one more thing about ipilimumab and nivolumab as far as adverse effects. So these are two immunotherapy drugs that we use in this setting. We use them for a lot of different things, actually, but particularly they're used in the management of renal cancers with poor risk. They're both infusional therapies. The adverse effects that I went over before, with one drug, there's definitely a lower incidence. And they don't compare, or haven't yet in studies, using one immunotherapy versus 2 immunotherapy drugs and the adverse effect. But I took a look at a couple of studies, one of which was nivolumab alone versus one of the VEGF drugs, and 19% of those patients had grade 3 or 4 adverse effects versus the combination of nivolumab and ipilimumab versus one of the VEGF drugs. 46% of those patients getting that combination had grade 3 or 4 adverse effects. So the point being that if you know a patient is on a combination immunotherapy, that they're more likely to develop adverse effects, and we need to monitor them more closely. And last but not least, the mTOR inhibitors, your temsirolimus, your everolimus. These are targeted therapies that are used in the setting of renal cancer, and in some other cancers too, and can cause a lot of the side effects that we've already talked about. So I'm not going to go into great detail, but just take a look out for mucositis, rashes, metabolic abnormalities, so checking labs is important. One of the things that we don't see with a lot of the other drugs is abnormalities in the lipid panel. So we don't routinely in oncology check a lipid panel unless we're giving one of these drugs that we know can cause issues there. Pneumonitis is another issue, and then it can cause some mild myelosuppression. So that's pretty much it. I know, I'm sorry, it was like a lot of lot of drugs there, but you know, that's the point. So the guidelines for the treatment of bladder cancer and for kidney cancer are constantly evolving. If I did this talk in 6 months, I probably would have different information for you as far as like what is recommended for first line, second line, and some of the management of the side effects too. So it's kind of important to be vaguely familiar with all of this, and then you know, if there's any questions, there's information is available. So thank you guys.